Hi, good morning, everyone.
Hi, good morning. Dr. Jabbar here. Can you hear
Hi.
me?
Yes, we can hear you.
All right. Okay.
Thank you, Jabba, for giving your time to speak to us.
It's
Maybe
okay.
we can start off.
My pleasure to give a talk.
Yeah, thank you. I think we can begin.
All right. So are we expecting some more to join?
I think they would trickle in slowly.
Okay.
Yeah, we can get a head start. Thank you.
Okay. All right. Okay. Good morning, everyone. I'm Dr. Jabbar. As most of you have known me, I'm in charge of the ICU in Queen 2. So sepsis and septic shock is a very important topic that we encounter almost every week. We have some few patients of sepsis and septic shock. So yeah, it's quite hard to manage the fluids and vasopressors. So I will try my best to give some of my thoughts based on the latest evidence available to us at this point of time. Okay, so if you watching this 5 years later, maybe everything could be totally different. So I don't know. Okay, so let's begin. So my topic for today is balancing fluids and vasopressors in septic shock. So I'll be giving my talk in this flow chart where as we go on through the topic. So first I will talk about patient with infection, the diagnosis of sepsis and septic shock, and then we go on to the assessment of adequacy of the perfusion. Okay, and then we want to have a look at the other types of shock other than these two, sepsis and septic shock. And then we will look upon the intervention to improve perfusion, which is the main topic for today. So first, let's begin with the diagnosis of sepsis and septic shock. So there's three things that we need to take into account for the topic today, which is infection, sepsis, and septic shock. Okay, and so in the international society, there is two main society that is supporting the surviving sepsis campaign, which is the Society of Critical Care Medicine. And then just a moment, the participant can mute yourself. Okay. So the Society of Critical Care Medicine and ESICM, European Society of Intensive Care Medicine. So they combine since early 2000 to give a sort of a guideline and guidance towards the management of sepsis and septic shock. Because in early 2000, mortality of septic shock reached up to 60 to 70%. So they come up with two different groups through different working groups. So one working group is for task force for that sepsis definition, is how to define the sepsis itself. Okay, another group is tasked with for sepsis management, which is the surviving sepsis campaign. So in the world, we have three big groups for intensive care, which is the USA, CCM, ESICM, which is the Europe, and another one is NZICS, the Australia New Zealand Intensive Care Society. So these two society combine to produce these two task force. So the first question is, does infection equals to sepsis? So if you look at the actual definition in the dictionary, infection is a state produced by the establishment of one or more pathogenic agents in or on the body of a suitable host. So it's just an invasion of a bacteria into the body. It's called infection, and can produce symptoms and can produce illness to the patient. So how about sepsis? So definition of sepsis have been going through several changes in early 90s. So prior to the creation of the task force, they call it sepsis 1, the pre-publication consensus on sepsis in 1991, and then we're going on into the sepsis 2 in 2001, where the first publication of surviving sepsis campaign was launched, and then it comes out at the sepsis 3, the latest one in 2016, come in with the fourth publication of the SSC, Okay, so all right. So sepsis 1 and sepsis 2, in the beginning, they define sepsis as one suspected infection plus a SIRS, which at that time the presence of 2 or more, temperature, heart rate, respiratory rate, and white blood cell count. Okay, so but if you look through the history, in sepsis 2, where the first publication was done by SSC, the sepsis criteria includes the SIRS criteria, and then there is also a severe sepsis, and then there comes the septic shock. So for sepsis 3, there's only 3. Can the other host help me to mute other participant? I can't keep muting myself and give talk at the same time. Okay, so the simple infection, sepsis and septic shock. So let's move on. So the traditional definition of sepsis is suspicious infection plus 2 or more SIRS, and then the severe sepsis, sepsis plus organ failure, and septic shock, sepsis plus refractory hypotension. Okay, the sepsis 3 definition, suspicious or non-infection plus increase of more than 2 SOFA score. Severe sepsis is not a category anymore, and sepsis plus vasopressor and lactate more than 2 is considered septic shock. Okay, so regarding SOFA score, is a 1, 2, 3, 4, 5, 6 category of organ dysfunction measured by the increasing amount of score, indicating the severity of the organ dysfunction. Okay. So the number one improvement that we need to make is that we need to properly diagnose sepsis and septic shock, and not diagnose infection as sepsis or septic shock. So number one, if a patient having an infection and no organ failure at all, depends on the SOFA score, and also whatever organ dysfunction that you think your patient might have, and the patient is septic looking, patient just looks sick, it's actually not sepsis. It's just an infection, because infection patient also can have lethargic, ill looking, and looking sick. And having infection with some organ failure, however, the organ failure is just 1 and maybe not so much, the SOFA score less than 2, increase from baseline, and also septic looking, patient looks sick, lethargic, and so on, is also considered as just an infection. So having an infection with significant organ failure, SOFA score of 2 or more, increase from baseline, septic looking, or even well looking, when maybe patient still looks well, doesn't look very ill, doesn't look septic looking, okay, but patient already having some significant organ failure, increase of SOFA score more than 2 from baseline. That means if patient having CKD before, the patient SOFA score at baseline already high. So if there is an increase of SOFA score more than 2 or more from baseline, it's considered significant new organ failure, and plus an infection, so it's considered as sepsis. Why important to label as patient as in sepsis? Because the sepsis 3 definition was based on the increasing mortality as according to the diagnosis. So when you label a patient having a sepsis diagnosis, the mortality increased by more than 10% when the change of SOFA score by more than 2 from baseline, if appropriate treatment is not given. So this is very important to recognize that patient is having a higher degree of mortality. So having an infection with a significant organ failure and normal lactate, normal BP, and patient look really ill, is not septic shock. Okay, so normal lactate and normal BP, normal perfusion, and not on any vasopressor, it's not septic shock, it's sepsis. So yes, but even though a patient is not in septic shock, yes, patient do need treatment. And if patient having sepsis, infection with significant organ failure, with high lactate, and patient need vasopressors to maintain adequate MAP, more than 65 mm mercury, patient is considered to have septic shock. And sepsis, so sepsis plus hyperlactatemia, more than 2, and need of vasopressor to maintain MAP more than 65 is considered septic shock. So with the above two combination, sepsis plus this lactate high and also requiring vasopressor, the two combination when occurred, sorry, I was disconnected just for a moment. Okay.
No worries. Welcome
Sorry,
back.
where were we? We were at the septic shock, right? Okay. Okay, so the two above combination when patient is having septic shock is the mortality is very high, up to 42%. So infection actually is a host response. When the patient having infection, the host response is usually normal when the patient is not having sepsis and septic shock. So when the patient is having sepsis and septic shock, it's actually the dysregulated host response that cause all the damage and all the organ impairment, organ dysfunction, and so on. Okay, so it's actually a improper or actually over response, hyper response of of the immune system, which usually called as a dysregulated host response. So it's not only the immune system, and all other system also is involved as well. So as I've shown this before, the sepsis 3 definition is the one that we are using now. So patient can be categorized either as sepsis or septic shock. If you notice, the severe sepsis in the previous definition is actually becoming sepsis in the new sepsis 3 definition. So severe sepsis is now no more a category, and septic shock is sepsis plus vasopressors and lactate more than 2. So this is so we need to start using SOFA score more when we want to diagnose patient in infection having either sepsis or septic shock. So the sepsis 3 actually came from a 5-year study from 1.3 million database. At the end, they include 700,000 participants worldwide, comparing between patient having infection, sepsis, and septic shock with the level of mortality that the patient is having. So how about the pathophysiology of sepsis and septic shock? If you want to treat disease, we need to know how does the disease comes about. And so what is the pathophysiology of sepsis and septic shock? So when the bacteria invade in your body, it can cause immune reaction and response by the immune system, causing the attraction of neutrophil, mast cell, monocyte, and so on. This will mainly cause two main pathways known for sepsis pathophysiology, which is the pro-inflammatory pathway mediators and anti-inflammatory pathway at the same time. So the pro-inflammatory mediators, which is the dysregulated host response, is an abnormal host response, which cause hyperinflammation and can cause, when it becomes more and more severe, which becomes a hyper response, it's not it's abnormal response, it can cause severe and deleterious effects too, and it can cause organ dysfunction. And anti-inflammatory mediators can cause increased susceptibility to nosocomial infection because it's sort of down-regulate the immune suppression. So in this, the other pictograph is a pro-inflammatory response causing excessive inflammation and causing collateral damage, which cause tissue injury. And anti-inflammatory response, immunosuppression with enhanced susceptibility to secondary infection. So what happens in the vessel level is that it will cause vasodilatation that can reduce blood pressure. And then some of the parts of the vessel can have some capillary and interstitial edema. But have you ever wondered why two different patients having similar clinical presentation of the same age and comorbidities, one will develop sepsis and another one just an infection, another one can have some very bad sepsis and septic shock, very bad organ dysfunction. So why does this happen? Okay, so the latest study have found out that some people have genetic predisposition, which can cause hyper response of immunity, which can cause more pro-inflammatory response, causing more chemokine and cytokines damage, and that can cause dysregulated host response and can cause pro and anti-inflammatory response, and then subsequently cause organ dysfunction. So let's move on to the management of sepsis and septic shock. So my talk will be mainly presenting about the SSC campaign, just published, I think, about a month ago in the SSC 2021 for the management of sepsis and septic shock. Okay, just remember, guideline is just a guideline. We need to tailor our treatment and manage our patient individualized and personalized. So it's now at the age of evidence-based and personalized medicine. Okay, evidence-based is just not enough with just guideline. We need to keep ourselves updated. So the management of sepsis, actually for me, I conceptualize it into three main category, which is one, antimicrobial, and hemodynamics management, and respiratory. So we'll be talking about more on hemodynamics management today. So the main treatment, main management of sepsis is actually source control of infection. And then early blood cultures prior to antibiotic and early administration of broad spectrum antibiotic. But today we'll be talking more about hemodynamics. So what is hemodynamics actually? So hemodynamics in human, actually hemodynamics is just a pump, which is the heart, connected to a parallel pathway of blood vessels, connected to in series and also in parallel micro circulation. So this is macro circulation, and inside the organ is micro circulation. So it's just nothing more than heart and also highways, series, parallel and series of highway of blood vessels. Okay, so there's a left side and also the right side. So let's talk about the formula of life. So the organs are the life for us, and then all the organs, the brain, kidney, livers, and so on. So let's learn a little bit about the organ perfusion. So when the blood comes in, with pumped by the heart, going through the vessels, and it calls a QB. QB is the blood flow into the organ. Okay, B is the blood, Q is the flow. So blood flow going into the organ, dictated by also the arterial pressure of the organ. So this actually blood flow can be detected by the DO2 formula, which is the oxygen flux. Oxygen delivery, global oxygen delivery formula. Okay, so this is the formula, which is the cardiac output, where is the most important pump, the only important pump in our body, and pumping the blood, which is this part, the arterial oxygen content. Okay, so the blood goes in and goes into the microcirculation capillaries inside the organ. So inside the organ, the pressure reduction is a lot, and then because it's becoming smaller capillaries, and then there is also pressure from outside the vessel, causing resistance against the blood flow. Okay, so imagine if there is a lot of edema, the edema can cause tissue pressure onto the microcirculation, and it can cause impairment of the blood flow. Okay, so this is the capillary, and then it comes out at the end at the vein, QB, out from the vein, and also the vein pressure. So actually the movement of the blood flow from arterial to venous end is due to differential pressure or pressure gradient. So if you have a venous congestion, you're giving too much fluid and fluid overload, what happens in the organ side, in the venous side, the venous pressure will increase and the pressure gradient will low. That's why we will have organ impairment, organ dysfunction. This is just one of the ways. So in septic shock, there are the multiple interaction on top of the direct injury from the cytokine and chemokines, and the edema from the tissues, and also increased venous congestion as well can cause reduction in organ function, organ dysfunction. Okay, so when we talk about hemodynamics, so this is what I usually think of when I treat the patient. When I see the patient in the ICU, I see what is the DO2. So is the cardiac output all right? How's the MAP? How's the highway? So if the pump goes is good, but the highway is too big, vasodilated, the organ will not have a good perfusion because the pressure is low and the pressure gradient is not well. It's not enough. That means the organ can be impaired. Perfusion can be impaired. So actually, management of everything, including sepsis, is to have good perfusion to all the organs. Okay. On top of, we want to treat the underlying abnormality or underlying diagnosis, we also need to make sure there is good perfusion to all the organs in the body. So next, I'll be talking about, when I talk about good perfusion to all the organs, what are the important things that we need to consider when we want to see whether the perfusion is adequate or not. Actually, based on the sepsis and septic shock, surviving sepsis campaign and many of the international guidelines, so they say clinical evaluation is actually the most important. So for assessment of adequacy of perfusion, this is what I usually do, and this is what I want to teach you guys. So number one is the pulse strength. You need to assess the pulse strength adequate pulse strength or volume globally, equally, comparatively between carotid, brachial and radial, and dorsalis pedis from central to peripherals, adequate same strength of pulse. When you do this, when you feel the pulse strength is similar, you are sure that the heart pumping is good, and also the vascular resistance is high enough to cause a good blood pressure, so the blood can reach the organs in their body lah. So number 2 is the capillary refill time less than 3 seconds. Usually we heard before in our medical school is 2 seconds, but newer study have shown up to 3 seconds is considered good perfusion. So 3 seconds or less should be a good perfusion, capillary refill time. Also have to be done globally, multiple fingers and toes. So you cannot take one finger and capillary refill time is 10 seconds and you just say, okay, perfusion is not good. So you have to measure, you have to assess also the other toes and other fingers. So don't mistake 1, 3 for the forest. So you have to see the overall picture of the patient as well. And then you have to see overall color of the skin, normal, whether it's a skin normal or not, and not bluish and not mottled. And you have to also see the temperature, differential warmness between the trunk and periphery. It should be almost similar warmness between the trunk and the peripheries. However, the most distal might be cold because we live in a air conditioned hospital. So number 2 is to measure the BP and heart rate. So non-invasive BP, ensure good cuff size, alignment of arterial marking is at the appropriate and medial side of the cubital fossa. Invasive BP, ensure good compliance of the system, 0 to equal with atmospheric pressure, ensure optimal damping. And we usually target MAP 65 mm mercury. And the heart rate target usually around 60 up to 120. So, but do not over worry if the heart rate more than 100. This usually happens in septic shock sepsis patient because they have baseline heart rate is normal for them is a little bit high. And number 3, we need to look at the organ function recovery to see whether the perfusion is adequate or not. The normal stuff, urine output trends at least more than 0.5 ml per kilo per hour, lactate value and trends of improvement like lactate clearance and improving metabolic acidosis, back success or bicarb level improving, CNS improving consciousness level and improving GCS. So next one, on top of the sepsis, on top of the septic shock, we need to look for other types of shock as well. So we look at the basic. What is shock? Shock is actually acute circulatory failure associated with inadequate oxygen utilization by the cells. So as it mentioned, shock is actually a hemodynamics problem. Okay. So it's mainly a hemodynamics problem that is in the 1980s in one of the landmark paper, one of the researcher divide the shock into 4. So which is a hypovolemic, cardiogenic, obstructive, and distributive. So hypovolemic is inside the vessel where the volume, plasma or the red blood cell is reduced. Okay, and cardiogenic is the failure of the pump, and obstructive is the failure of the pump to pump out the blood, not due to the contractility or pumping power. It's just obstructed physically from outside. And last one is distributive shock. So the whole of the highway becomes dilated and plegia is paralyzed or paresis, something like that. So it's a distributive shock. The last one. Okay, shock is actually the final common pathway prior to that. So you have to go through all the stations before you reach to the shock. And after the shock is termini. So it is the death. Okay, shock is the final common pathway prior to death. What is the most common shock in sepsis spectrum? So the main shock in sepsis actually is a distributive shock. Okay, in septic shock, it's actually a distributive shock. A minor amount of hypovolemic shock, not so much. The capillary leak is actually over-exaggerated. It's actually not so much. There is some capillary leak and fluid leak, but it's not so much. The best pictogram I could find is this physiological. Usually the amount of cardiac output is like this, and the resistant vessel is like this, normal, no more tension. In the pathological state of septic shock, it's the same amount of cardiac output. There is loss of vasomotor tone and resistant vessel. So usually SVR will be very low because patient will be vasodilated. That will cause hypotension. Most of the time, if diastolic blood pressure is low And then we call it a hyperdynamic circulation because the heart will be pumping. Actually, many of the patient will have high cardiac output. It's a high output high cardiac output, which with low vasomotor tone and vasodilatation and low SVR causing hypotension. So mainly it's distributive shock. So when we talk about the other types of shock, which is the obstructive and cardiogenic and obstructive shock. So there is one point of care ultrasound exam, rush exam. This is usually the favorite for emergency physician, and which is the rush protocol. So it's aimed to simplify and speed up undifferentiated shock by using ultrasound. So the chart is almost like this. So you want to scan for pericardial effusion. With I think within minutes you can know whether the contractility is good, whether the patient having obstructive shock or not, and then you can see actually whether the patient having pneumothorax, cardiac tamponade, and so on. So how about cardiogenic shock in sepsis? So initially I talked about the heart being normal or sometimes can be increased, but cardiogenic shock surprisingly is quite common as well in sepsis and septic shock. So usually the normal heart is like this and peripheral circulation is like this. In the early phase of sepsis and septic shock, there will be increased vasodilatation and increased permeability. And actually the main mechanism for cardiogenic shock is actually inflammatory chemicals and cytokines causing direct injury to the heart in early and late phase as well, and reduced myocardial perfusion due to low BP, low perfusion, and it causes lower perfusion to the heart itself, and increased metabolic demand because the infection causing sepsis and dysregulated host response causing a high metabolic demand, and then imbalance of the myocardial oxygen demand and oxygen supply. And also excessive fluid loading given can further worsen and push patient from early phase to late phase, which is more and more. The more you give fluid, the more permeable, increased permeability, and the more tissue edema, and can cause a worse cardiogenic shock or sepsis-induced cardiomyopathy. So up to 40% of patients in sepsis develop sepsis-induced cardiomyopathy. If that occurs, it increases mortality up to 300% if it's not diagnosed. Increased risk for SICM is actually in male, younger age, previous history of coronary disease, and lactate more than 4 upon presentation. The management is the same: antibiotic, reduced inflammatory mediators like steroids and hemopurification, dobutamine, and noradrenaline. So the obstructive shock, like usual tension pneumothorax and pulmonary embolism and cardiac tamponade. So next one is, this is the part of where I put the focus rush exam to look for other types of shock. So the next one is the main topic is the interventions to improve perfusion. So as we know, it's my conceptualized is actually this is concept for everything, not only for sepsis. So if patient having trauma, you can give blood. If patient having sepsis, you can give vasopressor. If patient having problem in the heart, cardiogenic shock, you can give inotrope. Having respiratory problem, you can improve the oxygenation. This is actually my own conceptualization of my intervention in the ICU to improve perfusion. So I mainly use this formula, and I always think about the whole circulation as a whole. So this is the arterial oxygen content. So arterial oxygen content can be improved by oxygenation when the patient having respiratory problem or patient in sepsis and septic shock. When patient having trouble breathing, you can give increasing support of oxygen support. But I don't want to talk about this today. So this is just arterial oxygen content, this part. And the cardiac output is comprised of stroke volume and heart rate. So what DO2 didn't address is that it didn't include the mean arterial pressure, which is the distributive shock. So when we give volume to increase intervention to improve perfusion, we actually, when we give volume, we increase MAP. We can also increase preload, which increase contractility of the heart. We also increase some amount of SVR that will in the end increase some stroke volume. When we give inotrope, we directly increase RV and LV contractility, which increase stroke volume, reduce SVR, MAP. Most of the time, dobutamine, milrinone, and so on, we can reduce SVR and MAP. And when we give vasopressor, usually the drugs that we give during septic shock, it can increase MAP and SVR. And by increasing SVR, it increase the venoconstriction on the right side, and increase venous return and increase stroke volume. So come to from the introduction, come to the main topic, fluid versus vasoactive agents. So based from the surviving sepsis campaign, we do know what really works for sepsis and septic shock is that we need to obtain blood culture. Number one, very important. You have to take blood culture before you give antibiotic in a meningitis patient or pneumonia or whatever infection that patient have. And we need to give and administer broad spectrum antibiotic suitable according to the source of the infection. Okay, so our 1 hour bundle in surviving sepsis campaign, we want to talk about this 4 and 5. This is a lot of debates occur internationally with these two. Okay, so the number 4 is actually to begin repeat administration of 30 ml per kilo crystalloid and apply vasopressor if hypotensive during or after fluid resuscitation to maintain a mean arterial pressure more than 65. Okay, so let's take a look on it. So we were taught by guidelines that's supposed to guide us, but with what evidence? Okay, so let's have a look. In the previous SSC 2016, they say that we recommend that in the resuscitation from sepsis-induced hypoperfusion, at least 30 ml per kilo of IV crystalloid fluid should be given within the first 3 hours. They even give strong recommendation, but actually low quality of evidence. This have been hotly debated for the last 5 years in international scene. They even say, as part of this, we recommend that initial fluid resuscitation begin with 30 ml per kilo within the first 3 hours. So actually they never say what weight. Is it ideal body weight? Is it actual? If 150 kilo patient, we need to give 150 times 30. That's so much of fluids. Okay. So what evidence they give to back this recommendation? So they say here, although little literature includes control data to support this volume of fluid, recent intervention study has described this as usual practice. But this is actually just an observational evidence to support this practice. So the observation study, they call it usual practice and even got strong recommendation. This has been heavily criticized in the last 5 years. So come in the latest one, after 5 years of debate and criticism, SSC 2021 comes up with a downgrade from strong, low quality evidence to weak, low quality evidence. So it's a weak recommendation. From recommend, they changed to suggest. For patient with sepsis-induced hyperperfusion, septic shock, we suggest, not recommend, yeah, that at least 30 ml per kilo of IV crystalloid fluid should be given within the first 3 hours of resuscitation. Okay, so you need to take into account the kind of words they use in actually giving guidelines. So it's a weak recommendation and just suggest only. So in 2016, in the 2021, they casually put ideal body weight, although it was not there in the 2016 guideline. So now we know they recommend actually ideal body weight for fluid resuscitation. So there are no prospective intervention studies comparing different volume for initial resuscitation in sepsis or septic shock. A retrospective analysis which caused the recommendation of 30 ml per kilo. So it's just a retrospective analysis. There is no prospective analysis done by SSC to recommend the 30 ml per kilo crystalloid fluid. So what is this retrospective analysis that they use to provide this recommendation? Okay, so actually this retrospective study actually done by the very people who provide the SSC guideline themselves. Okay, so study done by the SSC people themselves provide their own recommendation on 30 ml per kilo fluid. So, okay, so many patients in 2016, they say many patients will require more fluid than this. And for the group, we advocate that further fluid be given. So 2016 is very much pro-fluid. And comes to 2021, they put this fluid can cause potential harm associated with fluid overload. So from pro-fluid becoming restrictive fluid now, although they didn't explicitly say restrictive fluid strategy, and they mentioned that excess fluid can cause prolonged ventilation, progression of AKI, and increased mortality. Okay, never mind. Why don't we let's just accept 30 ml per kilo for initial resuscitation, the one that they have recommend. Okay, let's just accept it. But the problem is what I usually encounter everywhere, in Semenanjung here and everywhere, is the first district hospital when they receive the patient, they give 30 ml per kilo fluid. And tertiary hospital, the first doctor saw the patient, give another 30 ml per kilo fluid. Second doctor give another 30 ml per kilo fluid. So when they come in my ICU, my own ICU give 30 ml per kilo fluid. So from 30 ml per kilo fluid resuscitation becomes 120 ml per kilo fluid resuscitation. You imagine 70 kilo patient receive 8.4 liter fluid. And what happens if the patient is 120 kilo? There are tons and tons of fluid. No wonder our normal saline is number 3 highest expenditure by the hospital. So actually fluid overload is very, very dangerous, extremely dangerous. It can affect multiple organs and can lead to death, independent predictor of mortality in critically ill patient, and rising mortality due to fluid overload. Nowadays in the new age. So the recent study, one of the very, very big study by Wang et al. Just looking into the fluid overload, found in that 3,850 patients that the higher the fluid overload, the higher the odds of ratio of mortality. Because our body actually, if you look into many of the physiological study, our body is not designed, our body itself is not designed to sustain and maintain such a fluid accumulation in the body. Actually, our body is actually designed to withstand a lack of fluid, not overload of fluid. So this is the problem. And once the fluid overload causing injury to the patient, usually the injury is very, very, very hard to reverse. The most susceptible organs to the fluid is actually the kidney. Kidney is the most sensitive organ to fluid overload. And fluid overload, rather than deficit, is the main predictive factor for the development of AKI. AKI management is not about giving more fluid, it's about improving the perfusion to the kidney. So what happens is that excess fluid, distributive shock in septic shock, cardiogenic shock, some of the patients have cardiogenic shock, causing exit the lymphatic drainage, can cause interstitial edema, reduce in arterial perfusion. Remember the organ, the formula of life I showed you just now, and decrease ventilation and reduce tissue oxygen, and can cause AKI. So more fluid will lead to interstitial edema, compounded by leaky capillary in many sepsis and ICU patients. And interstitial edema lead to reduced tissue oxygenation and AKI. So 30 ml per kilo fluid resuscitation, what should have been done when the district hospital gave 30 ml per kilo, or it's equivalent to the first doctor, the tertiary hospital should start noradrenaline if the perfusion is not achieved yet. The second doctor should give usually give steroids to tone down the inflammatory response. And if you have vasopressin, you can use. And number 3 depends. So this is what I want to talk about. So 30 ml per kilo fluid resuscitation then should be followed by assessment of adequacy of perfusion. Touch the patient, check the pulse strength and color and temperature and so on. Measure the BP, and you have to look at the organ function recovery. If the patient recover after 30 ml per kilo fluid resuscitation, then you just stop. Do not give any more fluid resuscitation. Just give time. Most of the time, patient just need time to recover. So how about if you give 30 ml per kilo fluid resuscitation and patient having inadequate perfusion? So in the surviving sepsis campaign 2021, for adults with septic shock, we recommend using noradrenaline as the first line agent over other vasopressors. A strong recommendation. For adults with septic shock on noradrenaline with inadequate mean arterial pressure level, we suggest adding vasopressin instead of escalating the dose of norepinephrine. Okay, so for adult with septic shock, the third vasopressor is the adrenaline. So NORAD, vasopressin, and adrenaline. So how about when we have inadequate perfusion after the initial fluid resuscitation? Can we give some more fluid 30 ml per kilo again? Yes, you can actually, but how much is too much? Let's look at the best available evidence for fluid resuscitation in septic spectrum. Sorry, actually there is no randomized control trial supporting even the 30 ml per kilo initial fluid resuscitation, but because the recommendation they give actually just from observational and retrospective data, this actually originated from 2001 EGDT early goal directed therapies small RCT by reverse. Actually, in this trial, they showed mortality reduction by EGDT and agility group having higher SAVO2, fluid given, actually the fluids was given similar between the group. But I'm not sure how they come about the 30 mils per kilo, but recommendation from for the fluids for 30 mils per kilo have been extrapolated from this study. Actually, EGDT mortality success in 2001 have been attributed to early recognition of sepsis and early antibiotic and not fluids. So this is the amount of fluids given between the group and also the EGDT. Actually, the fluid given is around the same, up to 13 liter. So in year 2014, after that, large RCTs have been done challenging the EGDT. So as you can see here, the three studies actually given almost 1 or 2 liter lower than the initial EGDT trial, which have been used for recommendation for the 30 mils per kilo. So as you can see here, the smaller amount of fluid for initial resuscitation that you give, the lower the mortality goes. Okay. So all these studies quoted and mentioned never investigate the specific effect of fluid boluses as a standalone treatment. So at least this year, SSC downgrades the recommendation of 30 mils per kilo fluid initial resuscitation. So one of the interesting study in almost 50,000 patients in New York recruited to study the effect of speed of completion of SSC bundle, because it mentioned to finish in 3 hours, right? So actually between the two, shorter time to administration of antibiotics matters and improve outcome. So if you give the antibiotic within 1 hour, the mortality is like this. If you give antibiotic 12 hours after diagnosis of sepsis, mortality increase so much. But if you don't complete the 30 mils per kilo first fluid resuscitation, even at the 12 hours, the mortality is like flat. It doesn't change any mortality risk. Okay. So time to completion of bolus of the initial fluids doesn't matter. No change in mortality despite the time of completion of bolus 30 ml per kilo. So remember, septic shock is more of distributive shock rather than hypovolemic shock. So the latest trial, one of the biggest trial in 3,000, although it's in children, FIST trial demonstrated significant harm of fluid boluses. So in this study, they have 3 groups. In the first 8 hours, they give 40 ml per kilo albumin, 40 ml per kilo saline, and 10 ml per kilo, the no bolus group. So there is a higher mortality, much higher mortality in the fluids group compared to restrictive fluid group. Okay, as you can see, 7.3% mortality here, and the rest of the fluid mortality is 10.5%. So the p-value is significant, 0.01. And okay, so the conclusion is fluid bolus significantly increased 48 hours mortality in critically ill children with impact provision in these resource-limited settings in Africa. So how much is too much fluid? Actually, nobody knows. So, but indirect evidence shown at most initial fluid resuscitation and the first maybe 24 to 48 hours is actually at most is 30 mils per kilo. Usually, most of the time, patient need less than this. The key point is assessment and individualized treatment and approach. I like this table created by this IBCC. So initial when initial resuscitation of hypotensive patient with septic shock, do you have to assess, go clinically, assess volume status, clinical history, bedside cardiography, if you can do, increased risk of harm from hypervolemia, if patient having pneumonia, you cannot give more fluid. So the average patient actually need about 30 mils per kilo. So you can consider giving fluid slowly over several hours, not being too obsessed to finish it in 3 hours. Okay, you're done, great job, stop giving fluid. So in patient is clearly contraindicated to fluid, evidence of systemic congestion, lung failure, dialysis patient, and so on, low volume resusc, provide little or no pre-solid resuscitation. If you like to give a lot of fluids, you have to find a patient which is suitable, that have true hypovolemia, nausea, vomiting, diarrhea, reduced per oral intake, DKA, overdiuresis, and so on. So you can die and you can give a large volume of fluid. You have to but if you want to give a large amount of fluid, you have to also give it fluid slowly and have to follow the hemodynamics. So you're done, great job, stop giving fluid. So this approach only applies for patients who are hypotensive or on Vasopressors to improve their BP. So 2021 SSC, perhaps max is 30 mils per kilo and need individualization. Okay. So 30 ml per kilo fluid resuscitation you give in the first when the patient encounter the first doctor. But the usual problem is that inadequate perfusion after initial bolus of fluid. So what to do? So what most doctors do when you encounter with inadequate perfusion, you give the first 30 ml per kilo fluid resuscitation and you found that perfusion is inadequate, BP is still low, hypotensive, perfusion clinically is not good. You can you give either sometimes more, some doctors give more fluids and some doctors start vasopressors. So when you start vasopressors and then the perfusion is still inadequate despite increasing vasopressors. So you're thinking maybe patient doesn't have enough, is receive enough fluid, so you give some more fluid. Despite patient is already on vasopressors, already given fluid so much, and then you give more and more and more fluids. And some doctor even titrate up and up and up because they hear a lot of talks about fluids. Oh, it's not good, it's harmful. Okay, why don't we just try titrate up and up and up all the vasopressors to the max? So it's actually not the right way as well. Okay, so can't give more fluid, can't titrate up vasopressors to the max. So what do we do? So this is what I want to shine a light upon you, is that how to balance between the two. So when you give 30 ml per kilo fluid resuscitation and you still have inadequate perfusion, you start the vasopressors. Good, very good. Because in the SSC guideline, it says apply vasopressors if hypertension during or after fluid resuscitation to maintain a mean arterial pressure of more than 65. The next one I want to teach you is that you have to optimize vasopressors effectiveness before adding more fluid. So number one, to optimize vasopressor effectiveness is method one is to think of practical issues first. Effectiveness of BP measurement and effectiveness of delivery of the vasopressors itself. So method number one, think practical issues first. I want to talk about effectiveness of BP measurement. So for adult with septic shock, the SSC suggests invasive monitoring over NIBP as soon as practical and if resources are available. So anyway, most of the place don't have arterial line blood pressure measurement. It's okay. You can also use NIBP, but you have to know that NIBP measurement slightly less accurate than invasive arterial BP. This discrepancy and inaccuracy can be more pronounced in shock states, especially in distributive shock. Because distributive shock, the pressure is low at the periphery, so you want the pumping blood BP at the brachial, and then the BP, the pulse is already weak, so it's very difficult to get a good NIBP. Arterial lines catheter can be technically difficult. If you want to insert one, first pass rate can increase with the use of ultrasound. Complications are quite low, less than 1%, limb ischemia and bleeding. Most common complication is local hematoma, 14% at the radial side. Arterial line pressure transducer, which is the big cost, is 50 ringgit for one transducer. Okay, I've tried to get lower than this, but it's actually not possible. So most of the monitors in the HDU, ICU, all are capable, but the cables usually free when you buy the arterial line pressure transducer from the manufacturer. In extreme cases in ICU, we do insert femoral outline catheter. And actually 6% localized hematoma complication lower than the radial. And we need to use a set with guide wire. And this why we put femoral outline catheter, because most of the time the peripheral shutdown in the radial and also brachial, so makes it very, very inaccurate to have a good central systemic blood pressure. So in sites unable to monitor invasive BP, NIBP can be used. So, but think of the practical aspect. You need to be focused on the proper BP cuff size for different types and size of arm, placement of BP cuff, prioritize the arms. Okay. So the next one is the effectiveness of delivery of vasopressors. For adult with septic shock, we suggest starting vasopressors peripherally to restore MAP rather than delaying initiation until a central venous line is secured. When you delay in starting vasopressors, you want to give more and more fluid, or you think, oh, no CVL, cannot give vasopressor, cannot. If you delay starting vasopressor into achieve MAP more than 65, it can significantly increase mortality. We want to aim to reduce time spent below MAP less than 65, less than 1 hour. The lesser the amount of time the patient spend below MAP 65, the better the mortality become. We want to improve the mortality. Having said so, the most effective intravenous line for vasopressors is, of course, it's actually central venous line. 100% surety of delivery, targeted delivery into the central compartment of circulation. However, technically can be difficult and not without complication. And effectiveness of delivery of vasopressor, however, if CVL is not feasible to be inserted, if you cannot do, don't delay the vasopressors. Administering vasopressors via peripheral venous line is safe. Okay, only 3.4% cases of extravasation occur in the recent systematic review. Actually, they use 8 mg in 50 ml fluid concentration, the normal double strength concentration. So if you are scared, then you can use the single concentration, which is 4 mg in 50 ml of noradrenaline. Actually, there is no reported cases of tissue necrosis or limb ischemia in the 3.4% cases of extravasation. And it's in a small RCT of 263 patients with 1:1 ratio of CVL and peripheral IV line, shown most complication is actually not extravasation, it's actually difficult to get peripheral lines because, of course, vessel already collapsed, vessel dilatation is very bad. It's very difficult to get peripheral lines, so you have to put CVL as soon as possible. So, but the use of vasopressors in peripheral IV line safety can be increased by proper flushing and ensure the vessel, the line is still inside too. And Surviving Sepsis campaign recommend the use of anti-cubital fossa IV line. Okay, because 85% of the reported extravasation is due to lines distal to the anti-cubital fossa, which means in the forearm and also the hand. Okay, and you need to use it for the short period of time, less than 6 hours. If need longer, you need to insert CVL. Method number 2 is actually how to optimize the vasopressors effectiveness is to remind yourself is that MAP more than 65 is enough. Even in elderly, history of hypertension, background organ function deficiency, CKD, and heart failures. In this landmark study published in JAMA Network, is that they tried to do a permissive hypotension. Means that one group of very old patient with a lot of comorbidities. None of the patient included in this study is healthy. So all are having comorbidities. So one group, they lower the target of 60 to 65. And the other group is clinician discretion, up to the physician. They want to put 70, 75 is up to them. Okay, so what they found out is that in the end, although they target one group is 60 to 65 MAP, in the end, actually, the intervention group average MAP is 66. Okay, the control group median MAP is 72, the physician discretion. And actually, the mortality is similar. The outcome is not different. So that means even if you have a hypertensive, previously hypertension patient, diabetic, and so on, you can actually target MAP more than 65 is enough. No need to increase the target to 70 and so on. And at this point of time, when we look at this study, the mean dose of noradrenaline, they use about 0.12 mic per kilo per minute, and the highest dose is 0.26 mic per kilo per minute. And they add on another vasopressors, we still not achieve MAP and perfusion target. So there's some question that you might have when to start the second vasopressor is usually when you already optimize the first NORAD, and you still having increase, you still need to increase the NORAD to about 0.2 or 0.3. You actually suggested to add on another vasopressors. So all subgroup analysis, you see patient having chronic hypertension, chronic heart failure, atherosclerotic disease, all favors permissive hypertension group. So that means average MAP is around 66, 65. So the MAP target more than 65 is actually enough. Okay, but we do know some patients do benefit from more MAP more than 70 or 75, but there is actually a case-to-case basis. So then the method number 3 is that second vasopressor actually should be hydrocortisone. For adults with septic shock, this is a new change from the 2016 statement. For adults with septic shock and ongoing requirement for vasopressor therapy, we suggest using IV corticosteroid. So septic shock, dysregulated immune response causes resistant or deficient state of endogenous cortisol. Because you know endogenous adrenaline and noradrenaline maintaining our vascular tone. they also need steroid for permissive action of these catecholamines. So in septic shock states, there is a relative deficient or resistant of endogenous cortisol. That's why we need to supplement the steroids if the patient requires. Not all patient requires, usually in septic shock, and increasing requirement of vasopressors. So steroids in septic shock have been hotly debated since 1970s. As you can see here, they started with high dose of steroid, then they come down, then no steroid, then steroid again, on and off steroids. But now we know for sure that steroid is beneficial for patient in septic shock. So when to start? So if you look at the recent 4 studies, the mortality improvement only reflected in 2 studies. But if you can see here, time of presses all benefit. That means if you start hydrocort, the patient might the effectiveness of vasopressor can improve significantly and can lead to earlier offing the vasopressors. But the main recommendation actually comes from the Adrenal 2018 trial, where in adrenal trial it shows that in the 3,658 participants they recruited, and half of them in steroid, half of them in placebo. The time to resolution of shock is 3 days, shorter by 1 day from placebo. Time to discharge from ICU is 2 days earlier from the placebo, and they got extubated earlier by 1 day, and they used lower blood transfusion. This is the secondary outcome, but the main outcome actually the mortality is no different at 90 days. However, the mortality can be very it's a very complex thing in ICU lah. A lot of things can cause mortality, not just steroid lah. So however, we can see the secondary outcome is the main result that we can take from this trial. So I've seen the primary investigator myself. I talked and chat with him regarding this study. Actually, a very good, well done studies. So if you can see into the study some more, if you want to improve, follow the adrenal trial. The trial enrolled in the participant enrolled into trial if the patient was treated with vasopressors for a minimum of 4 hours at the time of enrollment. At that point of time in the study, noradrenaline dose was around 0.2 mic per kilo per minute at the point of enrollment. So indirect evidence that we can take, if the patient having increasing noradrenaline up to 0.2 mic per kilo per minute, we can consider hydrocort to be started to have this benefit of steroid hydrocort in septic shock. In the study also, interestingly, it has been shown that if the patient having the subgroup which benefit the most is the subgroup who had more than 0.2 mic per kilo per minute at the point of enrollment. So if they have 0.3, 0.4, the higher they were on the NORAD when they enroll the patient, when they give the steroid, the better the outcome for the subgroup of patient. So in this study, hydrocort group patient received hydrocort daily, 200 mg daily for 7 days. No bolus of hydrocort given. This I confirmed with the investigator himself during the conference. And they administered as continuous infusion. Usually we give 50 mg per QID, right? But in the study, they give infusion completing 200 ml every 24 hours. They give as an IV infusion. The infusion was continuously run at 8.3 mg per hour for 7 days. So no tapering at the end of 7 days. So at 7 days, just chop off through. So it has been shown in the adrenal trial, is safe treatment. Hydrocort is actually a safe treatment, except for hyperglycemia, which was double than placebo, 6 and 3. The problem is the infusion protocol is for us inadequate lines and inadequate syringe and infusion pump. From the other studies done, previous data and other studies suggest that infusion hydrocort is actually better for glucose control. And the 50 mg QID hydrocort is actually better for line and pumps management. So in our center, usually we prefer the 50 mg QID hydrocort. If you do have patient on this hydrocort for septic shock and they have uncontrolled hyperglycemia, you should change the 50 mg QID to infusion hydrocort. Okay. So conclusion from this study, from the safety part of the study, use infusion pump if patient develop hyperglycemia on QID hydrocort, and there is no need to taper. So the next one is method 4 is to correct electrolytes abnormality. So this is the summary of vascular smooth muscle contraction and stimulation pathway. As you can see here, the two main electrolytes is actually calcium and potassium. Okay. So this is the calcium and potassium is the two main electrolytes involved in vascular smooth muscle contraction. So calcium also is a main driver of myocardial contractility and heart rates. Okay. So in an interesting experiment done on 16 sheep, peritonitis induced vesicle puncture, calcium level falls significantly after induction of septic shock. So they take a 16 healthy sheep, they puncture the cecum, and then they cause septic shock in the sheep, poor sheep, and they saw a reduction in plasma calcium and reduced vascular and myocardial sensitivity to calcium. Mechanism still unclear and quite complex, but we do know in septic shock patient, actually hypocalcemia is common. Calcium in our body is like this, so blood plasma and free ionized calcium. Okay, so important to be corrected, but you need to avoid excessive correction, because excessive correction of calcium can increase issue acidosis. You have to look for ionized calcium, usually available in our ABG result. I usually aim to correct around 0.8 to 1. From the International Myeloma Working Group, the normal serum ionized calcium is 1.13 to 1.33. Such a tight, narrow range of normal calcium, right? Ionized calcium. So we need to see the free ionized calcium, because this part, if free ionized calcium is the one that actually is what matters, not the soil serum corrected calcium. So the potassium, the redistribution potassium imbalance is common. Both hyperkalemia and hypokalemia may occur in septic shock, and both are dangerous. Hypokalemia is more common initially, and multiple mechanism and interaction. Usually we aim to correct potassium to around 4, and other important electrolytes are magnesium and phosphate. And the number 5, if you have to treat severe acidosis aggressively, severe acidosis will render vasopressors ineffective. Patient usually come with acidosis, will self-compensate to reduce CO2 to improve pH, which is what usually found acidotic breathing in patient. If patient partially exhausted, you can supplement NIV. If patient fully exhausted or collapsed, you can insert the ETT. In this formula, when you increase the minute ventilation, which is tidal volume times rate, you can reduce the CO2 and you can improve the acidosis. You can use the respiratory part to improve the metabolic, to improve the pH. pH is what matters. So increase minute, in intubated patient, you need to increase minute ventilation by increasing tidal volume or rate or both without compromising the safety. Okay, so how about the use of sodium bicarb? So in Surviving Sepsis Campaign 2021, they suggest that for adult with septic shock and severe metabolic acidemia, pH less than 7.2, and having AKI, we suggest using sodium bicarb therapy. Okay. However, if there is no AKI and patient is having the pH is not too low, they suggest against using sodium bicarb, because sodium bicarb has a lot of harms if you use it blindly. And I encourage the use of sodium bicarb 8.4% pure instead of isotonic bicarb. Isotonic bicarb have more fluid and more harm, and also less effective bicarbonate ion per mils of solution, because you can unintentionally provide fluid overload to the patient. So by SSC guideline, use only if pH less than 7.2 plus presence of AKI. If no AKI less than 7.2, how? Okay. Use aggressively, quickly, if pH less than 7, even without AKI. This is from myself, not from SSC. And you can adjust ventilator to increase minute ventilation without compromising safety to reduce CO2 before you try the bicarb. Even if you increase the minute ventilation, the pH is still low, and you can try bicarb to buy time for the vasopressors to improve effectiveness, to improve the vasopressor effectiveness. Okay, so it's hard to change. Can I still give more and more fluids? Actually, fluid effect is unsustainable and not main issue in septic shock, and most of it is not retained in blood vessel. If you go and look and dig the rabbit hole, if you see the fluid effect sustainability in the body, actually at most is actually just 2 hours. After that, the effect of fluids will wane off. Okay, so most of the fluid, even if you're not septic shock, will not be retained in the blood vessel. So assessment of adequacy of perfusion, then you look for other type of shock. You do Poker structure exam, and you give dobutamine, chest tube, pericardial centesis, and so on to resolve the other type of shock. and you look into the intervention to improve perfusion. Most of the time, the main shock is distributive. So following the SSC, the first doctor will give 30 ml per kilo crystalloid. And then you do assessment of adequacy of perfusion again, inadequate. So you start vasopressors, good. Okay, you start NORAD as the first line of vasopressors. Don't delay, you can put in the peripheral lines, preferably at the antecubital fossa. Okay, and then make sure it's inside too, flush it first, and then you can use the vasopressors there. If you're lucky, perfusion improve, you can off the vasopressor even before you give hydrocot. So once you give the vasopressors, then you need to optimize the vasopressors effectiveness first. Okay, the last one I didn't talk about is ensure normothermia, because most of the drugs and also most of our body function need a normal temperature. So you have to optimize the vasopressor effectiveness. And then you have to assess again the adequacy of perfusion, whether the BP is all right or not, whether the perfusion is good or not. If it's still inadequate, yes, you can. Then comes the next question, or you already start NORAD, increasing NORAD. You already optimize the vasopressor, all the methods you have done, but still the BP is low, still inadequate perfusion. Do you give second vasopressor or more fluid? So this question of more fluid actually has been addressed in this. This question of more fluid actually has been discussed in SSC 2021. It says here, if fluid therapy beyond the initial 30 ml per kilo administration is required, clinicians may use repeated small boluses guided by objective measures of stroke volume or cardiac output. So you have to do fluid responsiveness test. This is called the suggestion. We suggest using dynamic measures to guide fluid resuscitation over physical examination or static parameters alone. So when you do fluid responsiveness test and the patient is fluid responsive, then what type of fluid you want to give? So we know crystalloid should be given, not colloids. Okay. So how about normal saline and balanced solution? So NS or BS, we should use BS, which is balanced crystalloid solution. So in the SSC say we recommend crystalloid, and then the other recommendation is that we suggest using balanced crystalloid. What are the balanced crystalloid that we have in our center? We have Hartmann, and we have sterofundin. Hartmann is actually quite good. It's not as cheap as normal saline, but it's quite good, and it's actually been proven in many studies that use it as initial resuscitation and also as fluid maintenance as well. So fluid responsiveness test. So when you already give 30 ml per kilo fluids and you already start the vasopressors NORAD and you already optimize the vasopressor effectiveness, and then you come to this point, do you want to give more fluid? So you have to assess the patient for fluid responsiveness test. So between static measures and dynamic measures, SSC guideline recommend dynamic measures. Static measure is heart rate, central venous pressure, and systolic blood pressure alone are poor indicators of fluid status. You want to get a better diagnostic accuracy. This is exactly what is written in the SSC. Passive leg resin combined with cardiac output measurement responds to change in intrathoracic pressures, whether it's a stroke volume, systolic pressure, or pulse pressure, fluid challenges, maxi fluid challenges, or mini fluid challenges. So the dynamic measures actually use the concept of Frank-Starling curve of the heart. So when the Frank-Starling curve is here, if you give fluid bolus response, you can see an increase of preload and increase of stroke volume. Cardiac output will increase, and then of course the perfusion will increase. If you do this test and the patient actually not fluid responsive, patient is actually already here not at the steep part. It's here. So when you give fluid bolus, it's only feeble response to fluid bolus. The preload, when you increase preload, the stroke volume will not increase as much. Okay, only a minimal increase in stroke volume with the same amount of preload or fluid that you give. So the more you give, the higher this curve goes, the more likelihood the patient will have fluid overload and problems. So that's why the second method should be vasopressor. As you can see here, when you increase the inotropy, the steepness of the curves become better, and patient can tolerate more fluid when the vasopressor is already there on board. Okay. So looking into more detail on this, passive leg raising combined with cardiac output measurement is actually difficult to obtain and needs special equipment and skill. You need a very specialized equipment to monitor cardiac output all the time, 24/7, every minute, every second. That's called cardiac output measurement in the outline or in the femoral outline. Usually we put, or you have to do the echocardiography, cardiac output VTI all the time while you're doing the passive leg raising. And respond to changes in introthoracic pressure. If you want to use variation of SVV, SPV, PPV, you need continuous arterial pulse contour waveform analysis. It's actually a very specialized device to see the variation. And if you give fluid challenges, you also need response of increased cardiac output measurement after fluid challenges. If patient not fluid responsive, fluid already given and may also worsen outcome. Okay. When you give fluid challenge, you have to see the improvement of cardiac output. Okay, so this is what is called as fluid challenges. And when you need when you need a cardiac output measurement, then you need a difficult special equipment and skill. And the suitable these methods actually suitable in ICU setting only if at all required. So how about in resource limited region? In our center, in resource limited regions where measurement of cardiac output or stroke volume may not be possible, they suggest a more than 15% increase in pulse pressure could indicate that the patient is fluid responsive, utilizing a passive leg raise test for 60 to 90 seconds. So how do we do this? So passive leg raising test, actually you have to do cardiac output measurement, which have high sensitivity and specificity as well. High specificity as well. And the other methods in resource limited region, improvement of pulse pressure, sensitivity drop quite low, but the specificity is also reasonably okay lah, high, 83%. So this will be difficult to do, but it's favorable. But this is recommended by SSC if we are in the resource limited region. So how do we do this? So patient in just a moment. Okay, passive leg raising test, improvement of pulse pressure is sensitivity 58%, specificity of 83%. We want to look at the more than 15% increase in pulse pressure that could indicate the patient is fluid responsive when we utilize a PLR test for 60 to 90 seconds. So this is the usual position that we do. We keep the patient 45 degrees semi-recumbent, and then we tilt the patient and lift the leg up 45 degrees like this. Okay, number 1 and number 2. So number 1, measure VP in starting position and calculate the pulse pressure, systolic minus diastolic. And then raise the leg more than 45 degrees and wait for 90 seconds. Okay, actually, in the meta-analysis, they say if the top part is supine, you can actually, it doesn't matter. Okay, but the proper way to do is like this. Raise the leg more than 45 degrees and wait for 90 seconds. Okay, when the 90 seconds have passed, you measure again VP in the leg raised position and calculate pulse pressure. If the pulse pressure more than 15% increase, next, give 250 ml balanced crystalloid fluid challenge. Okay, so that means the patient is fluid responsive. You have to remember, sensitivity is quite low, specificity is quite high. That means negative predictive value is high. If you found this, if the patient is fluid responsive, most may or may not, the fluid responsiveness may or may not be true, but its negative is very likely patient will not benefit from the fluid challenge. How about fluid maintenance? Usually the obligatory fluid needed for administration of food and drugs, we give drugs, they say 5 ml of vasopressor, 5 ml of this drug, Mida, 5 ml of fentanyl. When you add on all of this plus administration of food, makes routine administration of so-called maintenance fluid unnecessary. Okay, when you add on all the drugs, add on all the enteral feeding, rhizoid feeding, actually patient vessel requirement and makes routine administration of so-called maintenance fluid unnecessary. You do not need to give maintenance fluid if whatever the peripheral thing you give fluid for the patient is already enough. Okay, so the more important thing is that you have to look into is that for adult patient with septic shock who can be fed enterally, we suggest early initiation of enteral nutrition within 72 hours rather than starting maintenance fluid. If combined fluids used in drugs, which are a lot, like I said, during initial phase of instability equals the usual maintenance fluids, then specific provision of maintenance fluids are unnecessary. So one of the quotes I like from one of the famous intensivists in US, they are called maintenance fluids because they are fantastic at maintaining fluid overload. So this is the one that we have to look very, very, we have to be careful not to cause fluid overload for the patient. So we already optimize the vasopressor effectiveness, and then you assess the adequacy of provision inadequate. Then you talk about giving second vasopressor or more fluids. You do the fluid responsiveness test, you give fluid, patient is fluid responsive, then you give 250 ml of balanced solution, and use no or minimal maintenance fluid. Then you start, then if it's still inadequate, you can start second vasopressor, and you have to look into optimize the vasopressor effectiveness again, and maybe you can consider more advanced therapy, SLAT or CRRT. So in this, the small box here is a conceptualization of a treatment. You can give antibiotic. Yeah, the most important thing is really to give antibiotic, source control and oxygenation. And the first line is NORAD, optimization of the NORAD. Second line is vasopressin if you have, optimization again. And next one is adrenaline. By the time you start the third vasopressor, you need to think about end of life care. How about dopamine? Actually, dopamine is not really favored, but maybe you can use if you don't have other noradrenaline and so on. You have to talk about end of life care when you reach the third vasopressors already. After you have already done all the right things, all the correct things lah. Fluids, beyond the first 30 ml per kilo, you have to do fluid responsiveness test, and you have really think whether the patient really needs fluid or not, because the main issue is actually the distributive shock. Okay, so always reorientate the patient management and timeline when the patient already admitted in the medical HDU. So when the patient first came in or encounter with the doctor, the resuscitation period, you give 30 ml per kilo max fluid, start vasopressor. In the next hours of care, you titrate the vasopressors, optimize the vasopressors, and assess the adequacy of perfusion. And at the stabilization phase in the medical HDU and ICU, you need to wean off the vasopressors, and maybe you need to diurese the patient. The patient is overload. And no to minimal fluids, prioritize oral feeding. No to minimal maintenance fluid, and prioritize oral feeding, and de-escalate everything during when patient gets better. So we always talk about antibiotic stewardship, but we also need to talk about fluid stewardship in septic shock. So this is a nice picture that show that fluid resuscitation can cause incisional edema, visceral swelling, intravenous hypertension, mesenteric vein compression, causing venous hypertension, and oliguria. Okay, so this is I think you can read on this later. So this problem, giving 30 ml per kilo, 30 ml per kilo, 30 ml per kilo, 30 ml per kilo, and so on, we don't want this to happen. So always calculate the total fluids of what have been given before our review. Every time you will see the patient, how much fluid have been given before. Okay. So the conclusion from my talk is that this busy slide is that first you need to improve the diagnosis of sepsis and septic shock according to strict criteria of the sepsis 3 criteria. And then the next one you need to give blood, you need to take blood culture before antibiotic. You need to give broad spectrum antibiotic, source control, and also provide good oxygenation. And also you need to abide by antibiotic stewardship practices. Okay. And then first you need to assess the adequacy of perfusion. You need to touch the patient, measure the VP, check for organ function recovery. So you need to keep in mind the main mechanism of shock is distributive and some amount of hypovolemic. Okay, so at the same time, you need to look for other types of shock. You need to do some exam, point of care ultrasound, and so on. You need to look for cardiogenic shock, and you need to look also for obstructive shock. Okay, some X-rays and so on can do for pneumothorax. And then the first one is you have to give the initial 30 ml per kilo balanced crystalloid, and then you need to reassess again for adequacy of perfusion, whether the BP is alright or not. It's still inadequate. Touch the patient, measure the VP, organ function recovery, still inadequate. Then you initiate the vasopressor, and you give the first vasopressor is noradrenaline, and you optimize the vasopressor, like as I've told you before. at any point of time, you can give renal replacement therapy according to usual urgent indication for RRT, and you have to do, after you optimize the first vasopressor, you need to do fluid responsiveness test. You can give fluid bolus, assess again, then do responsiveness test again, give again if patient required. If you think the first vasopressor already optimized, all the hydrocort lines, BP all already good, then pH all good, you think you already given more than enough fluid, then you can start second vasopressor or may start RRT at any point of time. The second vasopressor is recommended to be vasopressin, but before you reach vasopressin, you need to do a lot of things before you reach vasopressin. Okay, you start the vasopressin, you already increase the vasopressin, and then at this point of time, you already need to start to do end of life care discussion. And at all time, you need to discuss goal of care with the family. Okay, if the family say she's already quite old, we don't want her to suffer, then we do not need to go through all of this, and we can save some resource for the other patient that requires it. Okay, so the third vasopressor should be adrenaline. And if you're already given noradrenaline, the perfusion is adequate, you can go to the normal pre-curve vital sign monitoring, continuation of IV antibiotic, refer ICU or high dependency, and you do source control intervention. Okay, so if patient is all right, improving, then you can go to this pathway. Okay, so end of life care decision should be initiated when you are at the second or third vasopressor, provided you have done all the right things here. Okay, so how about balancing fluid and vasopressor? So from this talk, actually we should titrate a little bit more vasopressor and use it optimally more than fluids. Okay, so you have to be very mindful and very careful with the use of fluid. Thank you.
All right, thank you, Dr. Jabbar. Azmat here, by the way.
Any question from the participant?
Yeah, any questions from the floor? I thought it was very extensive and comprehensive. Thank you very much. Any questions in the chat?
Yeah. Dr. Jabbar, Paul here. Got a few questions. Do you support the lactate guided resuscitation? Because sometimes we see after we resuscitate, the lactate come down, or within vasopressor, the lactate come down. Then after a few hours, the lactate come up again. Does it mean that our resuscitation is insufficient? Then we have to
sorry, my speaker was turned off just now. Can you repeat the question?
Oh, okay. Because do we follow the lactate guided resuscitation? Because like initial part lactate was high, then after our resuscitation, the lactate will come down. But after a few hours, if the lactate come up again, does it mean that we have to up titrate our either fluid resuscitation or vasopressor resuscitation again?
Okay.
Means we follow the lactate, like if high, then we adjust. If low, then means we are right, something like that.
Okay. You have to know lactate guided resuscitation is actually popular in 2016. So at that point of time, the pathophysiology was believed to be mainly because of hypoperfusion in septic shock. So nowadays they know we know that the lactate increase actually not only due to hypoperfusion, it's also caused by the increased metabolism. So the lactate guided resuscitation is okay when you have a lactate clearance more than, if I'm not mistaken, around 20% lactate clearance. That means the perfusion is improving, and you can use lactate guided resuscitation. But you have to keep in mind as well, there are a lot of other factors that can contribute to the increasing lactate, such as liver failure, use of adrenaline, use of salbutamol and beta-2 agonists that can also increase lactate. Yeah, of course, increasing lactate can mean hypoperfusion, but you need to take it with a pinch of salt, knowing that some other cause of lactate, some other cause can increase the lactate. And you need to really personalize and individualize your approach to the patient lah. You need to combine everything lah. Because sometimes when I saw the patient, the BP is good, great, contractility good, and then perfusion is good, everything is well, but the lactate is increasing just a little bit from, let's say, 4 to 6. Actually, I don't take lactate only as the my main goal and targets. Previously, because when we don't have lactate, I don't even use lactate at all for treating septic shock patient. I don't even look at the lactate. So nowadays, when we have lactate again, that's a little bit can be a little bit misguided, I would say. So look the patient holistically and not only at the lactate, because nowadays we know the lactate guided resuscitation evidence has been waning, coming down and down.
Okay, thank you, Dr. Jabbar. The other question is regarding the inotropic support. According to a slide, it's more of a sequential titration, like after first one maximized, then second one. Do you support the use of two types of inotrope starting at a low dose rather than one maximizing one and then go for second and then go for third?
Okay, if you follow my slides carefully, I never say to maximize the noradrenaline or the first vasopressor. Actually, I discourage the use of maximizing one norad, because if you see the slides and if you read carefully SSC, it says that they suggest to use two vasopressors rather than one vasopressors at maximum dose. Okay, so that's why I say just that when you start vasopressor, you need to optimize the vasopressor effectiveness first. And then at the point of time when you reach around NORAD about 1.2 to 0.3, you need to think about hydrocot as a second vasopressor. And if you already optimize them well and you do responsiveness test, you don't think patient needs more fluid, then it's better to start a second vasopressors, either adrenaline or vasopressin. I know vasopressin is quite expensive. You can use adrenaline as the second vasopressors. And yeah, the answer is it's actually not right to keep maximizing the vasopressors to 1 mic per kilo, 2 mic per kilo when the delivery itself is very bad. Let's say peripheral line. Okay, you know, you start peripheral good, you start early, and the vasopressor increasing. When the vasopressor increasing, you need to think about the delivery of the vasopressor. So you should put CVL early. Okay, number 2, then you have to look at the pH, whether the pH is good or not. Then you have to look whether you already started hydrocot or not. Then whether all the electrolyte imbalance already there or already corrected or not. So if all good, everything is well with the NORAD, fluids, electrolytes, pH, hydrocot all already given, at the point of 0.2, 0.3, you need to start thinking of second vasopressors already. Okay. The reason why vasopressin is recommended as a second line, because it works as a different receptors compared to the NORAD. NORAD works at the adrenergic receptors, while vasopressin acts at the vasopressin receptors. So if you, although vasopressin is not really readily available, quite expensive, you can use adrenaline on top of noradrenaline if your noradrenaline is increasing. So you do not have to wait until maximum. Okay, you can start a new vasopressors on top of the first vasopressors. But the more important thing that I want to highlight is that you need to improve and optimize the vasopressor effectiveness.
Okay, thank you, Doctor. The third question is the fluid responsive. We usually, most of us, like, will use the IVC guided, like the scan, improvement IVC or collapsibility to guide our fluid management. But there's a lot of confounding factors for the IVC. So do you have any suggestion regarding this?
Okay, among all fluid responsiveness tests, the worst and the least reliable is actually IVC scan. Okay, this has been studied extensively. I think about more than 30,000 patients. So much study have been put into IVC, and turns out to be IVC is quite bad, actually, to predict whether the patient is fluid responsive or not. The best way to use IVC is that at the extreme point of measurement. Number 1, we do not know where to scan and where to measure. Some say 2 cm. Actually, there's no study backing 2 cm from the RA. Actually, number 2 is that, like you said, a lot of confounding factors. Right ventricular failure, abdominal pressure high, some obese patient also. Okay, it's not reliable. You need to have a paralyzed patient at mils per kilo tidal volume. And then, so comes to a point where does IVC matters? Actually, IVC matters in extreme condition. When you scan the patient, IVC is totally collapsed. Okay, but you need to take into account is that if patient having high intra-abdominal pressure, of course the IVC will totally collapse. Okay. Number two is that patient having high inspiratory breathing pressure, negative pressure ventilation, high inspiratory breathing also can cause collapse. It doesn't mean patient needs fluid. It's just IVC collapse. Okay. And then another one is the other extreme. If patient IVC is like very, very dilated, 2.5, 3 cm, the whole length of the IVC, right? You scan the whole length. Okay. Most likely patient cannot take fluid anymore. Most of the time, if patient having RV dysfunction, you need to give the vitamin, improve the RV function first. Then only the IVC will start to slowly coming down. Then patient can receive more fluid when you improve the RV function. So for me, IVC between the 1 to 2 cm actually is very weak. It's a weak test to predict fluid responsiveness. It's evidence-based, man, so I cannot. Sorry.
Okay, thank you, Dr. Jabba.
Hi, Dr. Jabba. We have another question in the chat box, if you don't mind to look at the chat box.
Yeah, call here. Okay, for all patients, the threshold of starting vasopressor is quite low because the initial amount of fluid resuscitation is only at most 30 mL per kilo. Most patients need less than that. So in fluid sensitive patient like CKD on heart failure, no, I do not agree with 250 cc small boluses. So 250 to 500 cc is considered maxi fluid. So in this kind of patient, we give mini fluid bolus. Mini fluid bolus is 50 cc or 100 cc. Then we can see the improvement of the fluid responsiveness. So yes, we give lower amount. We call it MFCC, like mini fluid challenge. The 250 and 500 is maxi fluid. Okay. Threshold is quite low. So like I said, if in an inadequate perfusion, already given some amount of small fluid, then it's not improving because mostly it's distributive shock. So you need to start vasopressor early and optimize the vasopressor.
All right, thank you, Dr. Jabba. Is there any other questions? If there's none, we can close our session. I think all of us learned quite a lot today, and our practice have been actually quite wrong after learning to this lecture. So appreciate your time again, Dr. Jabba. It was almost 2 hours.
Okay.
Yeah.
No problem.
Do you have any last words? No.
And if any of you guys wanna ask anything or any suggestion for the next topic, can let me know.
All right, sure, we'll definitely do. Sometime in January for you, or February?
Yeah, January. Okay, should be fine.
Okay. Okay.
We have
Right.
another one
Thank you.
upcoming next week. Then I can give you guys the links
Okay. Yeah.
from our
Thanks.
side.
Okay,
Okay.
thank you, Dr. Jabba.
Okay, all
All
right.
right. Assalamualaikum. We see you all again soon, and have a good day, everyone. Thank you.